Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com.
All right, everybody, welcome back to the DaVinci Hour podcast. We are here with Dr. Matt T. Brown, and he is a cardiology fellow here at Emory University and recently finished his internal medicine residency, where he was actually my senior resident when I was a TY intern in the medical ICU. So Matt and I had a lot of fun on that one. And we're gonna have a lot of fun on this one too. Just a little background on Dr. Brown. He did his undergraduate work at Duke University and then earned his MD from the Medical College of Georgia, just nearby here in Augusta, Georgia. And then, like I said, just finished his internal medicine residency here at Emory University as well, and making his way through cardiology fellowship now. So Matt, thanks for joining us, man. Really appreciate it.
Thanks so much, Maxwell. It's great to be a part of the program.
All right, Matt. So to kind of kick us off here, why don't you kind of take us through a typical day on the inpatient service for cardiology fellow? Like, what time do you get there? What are your kind of like your main responsibilities, like the workflow, those types of things?
The workflow is very dependent on which rotation I'm on. But the typical day is usually starting at 8 in the morning and running to 5 when all our pagers flip to the on-call Cardiology Fellow. But right now I'm on the general cardiology service. So my day typically looks like very similar to how you would expect a medicine resident's day to go. I'm rounding on all our primary patients and chart reviewing. But in addition to that, I'm reviewing any diagnostic tests that we've recommended, whether that be an echo, a stress test, or if someone's had a cath the day before, then I'm looking at those films and interpreting exactly what the reports are saying and making sure everything adds up. I'll be working with interns. I'll be working with nurse practitioners and APPs, and also seeing cardiology consults, which is kind of a different side of things from the typical medicine residency. Now, I do have full months where I'm on imaging rotations, and that is like a totally different language, very, very different in terms of both learning how to perform these studies correctly, mainly transthoracic echoes, but also transesophageal echoes. And then on the flip side, learning how to interpret those imaging. So I'm back to the books, and I'm working with my cardiology attendings to be able to review reads and be able to pick up on things that I thought I was pretty good at determining ejection fraction, but now these numbers that I'm reporting are going in the reports. So it's very different. It's gaining a lot more responsibility.
Sure. And I guess kind of going off that, you mentioned that now you have, which I imagine is kind of maybe an unusual experience, that now you have, you have medicine residents working under you or working, with you on the service. I guess what do you feel like is the biggest change you've noticed in like your responsibilities versus like being the medicine resident on the cardiology service versus the cardiology fellow?
Yeah, this is it was an interesting experience, a transition from third year medical resident to first year cardiology fellow. And, it just happens overnight. And I ended up starting my cardiology fellowship on one of the same rotations that I had done 3 years before as an intern. And the biggest difference was really taking that first call from the ED, from somewhere in the hospital medicine for a consult, and being able to listen to the story and having the first take on what the next step was going to be, whether it was, go we need to kind of work this up further. We need to do some diagnostic imaging first. We need to stress, or we go directly to the cath lab. And of course, during my first month, I was always talking things over with the cardiology attendings to make sure these plans were along the right lines.
Sure.
So I think it's really that step up in responsibility, and then at the same time, really being able to review the diagnostic imaging that's been performed on patients, and really feel comfortable making decisions based off of those, rather than just relying on the report that's kind of generated in front of our eyes.
Sure. And I feel like you've touched on this. It seems like also kind of making those higher level like management decisions is now like more in like kind of more in your hands. Because I feel like I remember as an intern, always when I would consult cardiology, like I usually would talk to the fellow, and usually I was like always so impressed. Like the fellow, like, would get back to me and they'd have this like clear plan, and like they'd say like do this and that, and then I guess it seemed to more like fall on the fellow. If does that seem fair to you? Or
yeah, being on the consulting side of things, it is a very different feel than making all the primary decisions. I think when you're being asked a specific question, you're able to kind of focus in and still consider everything that's going on, and then be able to come up with that specific answer, or at least come up with the diagnostics that you need in order to make the most informed decision, whether that be getting an echo or sending someone for a stress test.
Gotcha. And then I guess kind of going off that, what, I think when people think of cardiology, they think of you guys, having to deal with, like heart attacks or myocardial infarctions, emergent issues. So I guess when you guys do take call, I think probably a lot of, listeners would be curious, what's your typical call shift like? What do you guys get called about? What are you kind of having to deal with? Those types of things.
Absolutely. Yeah, this was the most intimidating part of cardiology fellowship. I had no idea what calls were going to be like. And at Emory, we have a home call system. We're divided up across 4 different sites. Luckily, there's a good group of cardiology fellows and a good group at each site. So we divide up the month of call, and we typically have 4 to 5 kind of either overnight calls or weekend calls throughout the month. So, when our daily duties are over at 5 p.m., the pager turns to us, and I usually try to stick around the hospital for a little bit longer than I normally would, just in case anything comes through that I'm going to need to be there before heading home. There are plenty of occasions where we do get a call from mainly the emergency room, sometimes another ICU in the hospital, and the most emergent things that we get called for are pulmonary emboli. In that case, you need to go in and perform a transthoracic echo to be able to look for right heart strain. Usually after a radiologist reads out right heart strain on the CTP protocol.
Gotcha. And we put in our report better evaluated by cardiac echo.
That's the truth.
Yeah.
Cardiac tamponade is another thing that we get called about, and of course heart attacks, whether it be, and there's all different types of heart attacks. Usually we've adapted the high sensitivity troponin assay, so even the small troponin leaks, we do get called about, and it's up to us to be able to make the decision whether are we starting heparin, or are we what additional diagnostics do we need? Do I need to come in and do an echo and look for wall motion abnormalities, or is this bad enough? Is it a concerning enough story that I'm calling the interventional fellow on call to kind of hear out the story and decide whether or not to activate the cath lab? All those things don't, you hope and you pray, and all those things don't happen in one night. And there are nights where you're able to sleep soundly and not get called in. But it's it has been an experience, and every time I'm on call, I learn something.
That's awesome. Hopefully better experiences than those 28-hour calls you and I did together
Yes.
in the medical ICU.
Oh my goodness. Yes. Yes. Those were. We don't have any of those. I'm happy to say. No,
That's
no
that, that
28-hour calls.
yeah, that was something else, to say the least. But yeah, so it sounds like on call you're dealing with like more, obviously it sounds like either ER or the ICU is giving you a call about like an emergent, either a new patient coming through the door, or like you said, like someone who's already on the floor develops a PE or develops do you get called much about like abnormal heart rhythms or things like that, or like severe like persistent tachycardia? Is that something you guys get called a lot overnight about?
Yes, that is a very common condition to get called about, especially AFib with the RVR. And then you have to make the decision based on if you do have an echo to know what the ejection fraction is, then you feel more comfortable with certain agents. But if you don't, then you're kind of in this guessing game. And
Yeah.
luckily, there's an EP service around. So, if we have questions, then I can always reach out to the EP guys for some higher level thought.
Oh,
Um,
nice.
yeah, that is the great benefit of the academic setting, where there is an expert, whether it be interventional, EP, advanced heart failure, congenital, call away, and we have all those fellowships here at Emory too. So usually you can go through a fellow and get their advice.
We're going to take a quick break to let you know the DaVinci Hour podcast is brought to you by DaVinci Academy, which provides online video courses for the medical basic sciences. These courses are taught using a variety of teaching methods, including bullet point outlines, diagrams, radiology images, and chalk talks to explain the fundamental concepts. We then teach the application of those concepts to numerous clinical pearls that are frequently tested on medical school exams and the USMLE. Our video courses are available on our website, dviacademy.com, as monthly subscriptions starting at $9.99 per month. Each video course has a corresponding outline format textbook as well. You can find the link to our website in the description below. Also, be sure to use the discount code TDH20 to receive 20% off any of our video courses. All right, now back to the podcast.
So kind of going off of that as well, what are the typical rotations in a cardiology fellowship? I mean, it's 3 years long. Like, how does that time like broken up essentially?
Depends on the institution that you're at. Here at Emory, and I will say there is a guiding curriculum for cardiology fellowship. It's called the COCATS, and that is divided up into more or less 15 different kind of merits that you need to be able to meet over the course of your cardiology training. Among those 15 different kind of merits are different levels that you can advance through depending on how many procedures or how much exposure you get to certain areas. So every cardiology fellowship is built to be able to meet certain requirements. I will say here at Emory, our first year is very much so clinically based. There are a couple different tracks, and I'm currently a clinical cardiology fellow. So my first year is divided up among many different primary services, mainly between general cardiology, heart failure, and consulting rotations, where I'm acting as a clinical consultant for anyone in the hospital, whether it be general surgery, hospital medicine, OBGYN. Now, sprinkled in throughout this first year, we have some basic rotations in echo cardiography, learning how to both perform correctly the transthoracic echo, as well as the transesophageal echo, and then also interpret both those different types of studies, as the imaging and the views that you get of the heart are very different.
Yeah, I was just to say it's I think we were talking about this before we started recording. Just it's like doing ultrasound, but even more specialized. Like you responsible for learning how to do it, but then also how to read it, like you were saying. So yeah, I imagine that's a whole new skill set you've got to acquire.
Right. And every patient that I've encountered has very different windows and different. I've learned something every time that I've gone to perform a transthoracic echo myself. At the same time, there are different types of imaging rotations that we have, as we're responsible for learning how to appropriately perform and interpret stress testing. And there's a wide array of stress testing available, whether that be cardiac CT, which is gaining in popularity as a non-invasive diagnostic to be able to rule out large vessel occlusion.
Sure.
Or
Yeah, I can speak on the radiology list.
yeah,
We see more of those popping up these days. We see more of those
yeah,
popping up, and those are
and
pretty cool studies.
and it's very site specific. Which stress testing modality we kind of gravitate towards at Emory Midtown. They're kind of seen as the their specialty is really cardiac PET. So I've been able to sit down on some of those studies, even when I'm not on the rotation, but just kind of stepping into the reading room to follow up on my patients' studies from the general cardiology service. At Grady, it seems like coronary CTA is the way that they risk stratify, and similar to Emory University too.
Interesting. Yeah, no, it's yeah, I'm at Grady now on chest imaging actually, and we've seen a lot of coronary CTs come up. So that's pretty cool. Glad we can play a role in your guys' work as cardiologists for sure. I guess you're talking about a lot of different imaging and the different rotations. What are the like kind of subspecialties, if you will? Everyone in medicine knows there's subspecialties of general medicine, but I think maybe people may not realize that I feel like you and I talking about this when we were in the MICU, like there are a fair amount of like subspecialties for cardiology. Maybe if you could touch on that a little bit for people.
Yeah. So there are a lot of super fellowships available. The road to cardiology is 3 years of internal medicine, and then there's 3 years of training to become a general cardiologist. Now, at the end of those 3 years, you're board certified to be able to practice in cardiology. You can, and depending on your level of proficiency and kind of in some of the COCATs that we mentioned earlier, you can get echo boarded and certified. You've seen enough EKGs to be able to read all of those. But beyond general cardiology training, there are many super fellowships. There's pathways that lead towards interventional, and interventional is even branching even further nowadays into kind of two pathways beyond that interventional fellowship. And these, you would go through interventional and you would learn how to perform percutaneous coronary angioplasty, basically placing stents. And now they've even become even more specialized to be looking at structural procedures where they're doing percutaneous valve replacements and repairs, and sometimes together, they're even branching off to look into what they're calling complex coronary disease, or CHIP procedures, where you have interventionalists that have gone through further training to be able to learn how to open up chronic total occlusions, or CTOs.
Oh, wow.
And that is all down the interventional pipeline. That's, in the cath lab doing left and right heart caths. And so that is kind of an exciting pathway.
Sure.
Kind of on the flip side, looking at more of the electrical system of the heart, and how the heart conducts, there's a super fellowship and pathway for electrophysiology, where they're responsible for a lot of the ablation procedures that you hear about for atrial fibrillation or supraventricular tachycardias. They also put in pacemakers and defibrillators, and that's now a 2-year fellowship beyond general cardiology. And there are a variety of imaging subspecialties that have become available, whether that be structural imaging or more specifically like cardiac CT or cardiac MRI. And there is nuclear interest as well. I guess there are really two more. One that I'm very interested in, and that's advanced heart failure and transplant, where you're managing patients usually with both types of heart failure, preserved ejection fraction or reduced ejection fraction, and seeing them as they seeing patients in clinic and also in the hospital as there are heart failure specific services, and managing them throughout their disease process, and working on goal-directed medical therapy and exploring some of the more invasive options and potentially even heart transplant. Outside of that, there's also adult congenital heart disease with our growing patient population from the pediatric pool, where patients are born with tetralogy Fallot and different cardiac anomalies. And our cardiothoracic surgery team and pediatric cardiologists have become so successful in intervening early. As those patients grow into adults, and their physiology really changes. The whole field of adult congenital heart disease has really grown out of that.
Interesting. What's really cool about cardiology, it sounds like, is there's a lot of different avenues you can go with. You can go pretty procedurally heavy, or you can, if you're obviously more interested in some of the imaging aspects of things, you can kind of focus on that, and then obviously the more advanced kind of like medical management, like you were talking about with both the congenital heart disease fellowship and then the advanced heart failure. Is there a way to do like cardiac critical care? Like, can you be a cardiac critical care specialist because I think most people, when they think of critical care, they think of like pulmonologists doing it or anesthesiologists. Like, is that something cardiologists can subspecialize in?
Yeah, absolutely. There are plenty of ways to get into the critical care background. Actually, one of my co-fellows now, he's PulmCrit certified, and he's doing his cardiology fellowship on top of that.
Oh, wow.
I think he's taking some time to do. He's in our research track right now. Now, I'm not totally sure of the pathways. Usually, a lot of our coronary care unit or CCU physicians are adult congenital heart certified or advanced heart failure and transplant physicians. But even from the general cardiology side of things, there are avenues to get into the CCU as a generalist as well.
Interesting. Okay. And I guess with that, you would be responsible for, much like analogous to like a neuro ICU, where they both have to be experts in the brain and like high level, like, neurocritical care, but also just general. You probably are responsible for a lot of like the general medicine, like you would be responsible for in the ICU as well.
Absolutely. Obviously, the patients in the coronary critical care unit or CCU are going to be primary cardiac problems, but it takes a full knowledge of all the body systems to be able to best treat the patients.
Sure. You've mentioned like the cath lab and things like that. Are, as outside of like the interventional space, are there procedures you guys like that are kind of like your bread and butter procedures that you guys do, or your like diagnostic interventions that you guys do on a regular basis?
Absolutely. Outside of the cath lab, there are plenty of cardiology diagnostics, and a lot of them I'm involved with as a clinical fellow. A lot of it revolves around imaging. So the transthoracic echo is kind of our bread and butter. It lets us know about how the heart is functioning, what the structure of the heart is like, are there valvular abnormalities. The flip side of that is performing a transesophageal echo, which is most typically used when we're trying to rule out any sort of left atrial appendage thrombus, or evaluate for any sort of cardioembolic stroke etiology. That is a very common procedure in the cardiology world, and one of the things that we do very commonly on our echo rotations. And that is a very different feel from the as you can imagine, the transthoracic echo.
Sure.
We usually couple those TEEs with direct current cardioversions. We like to rule out thrombus with a transesophageal echo, and simultaneously, as the patient is usually has a little bit of moderate sedation, go ahead and shock someone back into normal sinus rhythm. Other types of procedures that we do are really device interrogations. Um, if someone comes in and they have a pacemaker and or more often a defibrillator, and we're concerned about any sort of ventricular arrhythmias, and if they say they've been shocked, then we'll grab the correct programmer, as most are device specific, and be able to interrogate a device. And we actually gain a lot of information about what the heart is doing and the rate and the rhythm that a patient has been in.
Interesting.
Yeah. On talking about arrhythmias, loop recorder implantation is another diagnostic that is not one of the top things that people think about, but is very useful for kind of the cryptogenic stroke population, or if someone is having palpitations and we want to rule out any sort of kind of paroxysmal arrhythmia.
Interesting. I guess, and then that being said, if someone does want to do interventional cardiology, do you guys get early exposure to those skills, or is that something you more refine like when you do go to interventional fellowship?
Absolutely. And I should have mentioned this when you asked me about my rotations,
Yeah.
because we do have a very heavy exposure to the interventional world. Every kind of cardiology fellowship involves time in the cath lab, and I just finished up 3 months of basically diagnostic left heart caths and right heart caths at Emory Midtown.
Oh, cool.
I was a person that was consenting patients for their procedures, and talking over the correct access sites with my attendings. And from day one was getting arterial access, getting venous access, most of the time using ultrasound guidance, and then putting our catheters through the vasculature. And I had some excellent teachers that were very patient, and I feel very confident after my 3 months and kind of mastering the diagnostic portion of the heart cath.
That's awesome.
Yeah, there's more to come. In my second year, we have an additional month, and what's really nice about the Emory's program is a lot of it is front loaded, where we go through and kind of check all the boxes of imaging rotations, consulting rotations, general services, and CCU months. And we're left with a third year that we can really tailor to our own liking, whether that be more time in the cath lab, thinking about interventional fellowship down the road, or more time on electrophysiology services, or even more imaging time, to be able to kind of get additional exposure to different types of imaging that are less commonly used, like cardiac MRI.
Interesting. Yeah, that's nice. You get that third year to kind of like focus on what you hope to do in practice. I guess one thing I'm wondering, can you do, as a general cardiologist, can you do many caths, or like the diagnostic type of like, cath procedures that you're talking about without having to do interventional fellowship? Or is that kind of the way things are now? Is that more falling pretty exclusively to the interventional cardiologists?
It is very interesting, and I think it's kind of evolved. Yes, as a general cardiologist, you're certified. You've had enough exposure and procedures to perform diagnostic heart caths, both right and left. Now, if the procedure turns, meaning you find a blockage, that's typically where you would call for an interventionalist to step in and actually place stents.
And then as far as on the other side of like the electrophysiology procedures you were talking about, are those pretty exclusively, like if you want to do those, you have to do the EP fellowship, or are there any of those that like a general cardiologist out in practice can do?
I'm drawn from some experience that my wife, who actually worked in the device industry, has told me about, and she's seen some general cardiologists placing pacemakers and other devices. But I think the majority of people that she has worked with were electrophysiology trained, especially for ablations. That's kind of their bread and butter, so to say. I think that sort of training is and is necessary for the ablation side of things.
Gotcha. And then I guess maybe tell us a little bit more about the area you're interested in, like the advanced heart failure. Because until you told me about that when we were like working in the MICU together, I wasn't really familiar. Like obviously I was familiar with like, you guys are dealing with critically ill, like heart patients and things like that. But I guess that this was a whole like other subspecialty in cardiology, which is pretty cool.
Absolutely. The area that I'm really drawn to within cardiology is advanced heart failure and transplant. And this is an area where there's a very diverse patient population. And I think that's what I like most about it. You can see patients of all ages with all different cardiac abnormalities, whether it be a mother with peripartum cardiomyopathy, a young child with some sort of congenital heart disease, or someone that is totally asymptomatic, but their family members have had heart disease and they've found out that they have some sort of familial trait or hereditary disease. So it really covers a wide array of encounters, whether it be in the outpatient setting, where, as you mentioned, when you think of heart failure, you think of kind of critically ill patients, but there's tons of patients walking around every day with reduced ejection fraction or systolic heart failure. And they're doing okay. They're on medicines that have proven mortality benefits. And in some cases, we were able to see that their heart function, while it was reduced at one point, has really regained some function. In the cases where that isn't the case, patients come into the hospital with acute decompensated heart failure, you're able to see a really big difference in a relatively short amount of time with high dose diuretics, and you just can see someone feel better over the course of several days, and really try to set them up for success as they go back out and get them into your clinic so that they don't come back into the hospital. Now, in the really refractory cases, say someone is admitted to the coronary critical care unit or the CCU, and they're in cardiogenic shock. There's so many different devices and technology out there to be able to manage somebody. And the ultimate is really undergoing heart transplantation. And that is where you get to work with a very diverse and interdisciplinary team, with coordinators and therapists, as well as the cardiothoracic surgeons, to be able to really plan and make sure that someone that receives a heart transplant is going to do well thereafter.
That's pretty cool. And then I'm sure that the interdisciplinary aspect is really interesting too. That's I'm sure it takes a complex team to manage some of those very complex patients.
Absolutely. I've been able to sit in on a few of the advanced heart failure transplant meetings. You have surgeons on the call, you have multiple heart failure doctors and social workers that have gotten to know the family, and not even just the patient, but the family members that are going to be supporting someone down the road. They really leave no stone unturned and want the best.
Yeah, no, definitely. It's it takes I guess something I didn't fully realize like to residency is the amount of support system these patients need, not just in the hospital, but when they leave the hospital, like you said. Going off, kind of winding it back a little bit, I wanted to ask you, I was curious, when you were in medical school, what did you know you wanted to do cardiology, or were you more just interested in like internal medicine and thought you kind of would figure it out in residency? Maybe kind of take us through your path to cardiology.
So going to the medical school, I really had no idea what was out there. I was a biomedical engineer as an undergrad, and I volunteered in the hospital, and I knew that I wanted to be able to interact with patients on a daily basis, and that's what drew me to medicine. I didn't really realize all the different specialties that were out there. So early on as a medical student, I went to every single kind of luncheon event to learn more about the different specialties. And, I took advantage of the opportunities to get more involved and to shadow throughout my first and second year. And then third year, I went through rotations. And, I think everybody, as they go through rotations, kind of keeps a checklist and kind of weighs the pros and cons. And I was really kind of up in the air, really going into fourth year. I think the thing that really steered me towards medicine was the amount of patient interaction that I was exposed to on my internal medicine wards. And from my first and second year, I was able to get involved in some research, and it happened to be with a mentor in cardiology that is still a mentor to this day. And I was able to shadow him, and so I got this kind of first glimpse of cardiology early on through that research experience. And then I knew the pathway to it was through internal medicine, and I did enjoy my time on the internal medicine wards, and I was able to gain more exposure in the outpatient setting during fourth year. And that's how I knew that it was going to be a fit.
Nice. And then I guess when you got to medicine residency, were you leaning pretty hard towards cardiology, or were you kind of keeping an open mind? And then I guess what during residency kind of clinched it for you to commit to cardiology?
Yeah, entering medicine residency, I did very much so have cardiology in mind. I really enjoyed my rotations through the general cardiology rotations, and then we had the opportunity to also rotate on the advanced heart failure service and through the CCU. Emory's program is very well ingrained with the cardiology program, and I loved every experience and was able to find great mentors and delve further into research with them after being exposed to their different teaching on service.
Nice. So you mentioned the path to cardiology, like you said, you have to do internal medicine, and then you do cardiology fellowship after that. So it's 6 years theoretically total. I guess what would your advice be to, I guess, medical students that are like, considering internal medicine, or maybe they're interested in cardiology, and then want to kind of go down that route, which I guess you mentioned, like, that you were involved in research projects and you did a number of shadowing. Is that kind of like it sounds like those were helpful for you, not only to help you make your decision, but also, help like with your application and things like that. Are those kind of the experiences you would advise med students to kind of seek out if they're interested in either medicine or cardiology eventually?
Absolutely. Looking back, I think the biggest thing that helped me kind of guide my path to cardiology was really the mentors that I had early on throughout medical school. They not only kind of gave me a glimpse into the world of cardiology, but got me involved in the research process. I think that exposure early on has really helped me with kind of continued research and other interests as well, and kind of the innovation space. Now, thinking back to medical school and working with medical students on services as well, I would say if you're interested in internal medicine, try to make the most of that internal medicine rotation. It is so busy, I know, but when you're calling consultants, take the time to ask them questions, ask them why there's certain decisions being made, and if there's going to be a procedure for one of the patients that you're following, I think what could help kind of further expose you into the world of internal medicine and subspecialties beyond is go ahead and ask if it's okay if you kind of tag along, and you're there for the procedure, you're there for if it's GI, for the endoscopy, if it's cardiology and your patient's going to the cath lab, see if it's okay if you tag along, and more likely not going to be able to scrub into these things, but just see what's going on and see what the cath lab is like, see what the endoscopy suite's like. If it's rheumatology, like watch the rheumatologist tap the joint, or go examine the crystals under the microscope. I think there's a lot to internal medicine, and it's a field with many different avenues. I think the kind of 6 weeks that you're on it, you can get caught up doing the same thing over and over again. But I think any good teaching team is going to want you to make the most of your experience and and see why they like it so much too.
Yeah, no, I think that's great advice. I actually remember as a med student, like I remember I had patients on medicine that like went to the cath lab and like going and watching the cath lab and how things are done in there. And it's an exciting place. I think even if you don't end up doing cardiology, it's just a cool thing to see, for sure. So yeah, no, I think that's great advice, and just getting the most out of like your rotation and you're getting that exposure. I remember when I was on wards, we always like encourage med students to like, go to a procedure, like you said, or go to the, pathology lab with one of the subspecialtists or something like that to look at a sample. So yeah, definitely. I guess kind of moving beyond that, and I think med students would definitely be interested in this too. Like when you're a medicine resident, what are kind of like the big things you need to like focus on if say you've made that commitment to cardiology, like what are kind of the things that the fellowship directors are looking for, or like what are like kind of the things the boxes essentially you need to check to apply to cardiology fellowship?
Coming into internal medicine, I already knew that I had a very big interest in cardiology. So I was able to start looking for mentors within the Emory system, and was lucky to find many right away to get involved not only in clinic, but also with research. And from that research, I was able to apply to some different conferences and get some abstracts presented as poster presentations. And from those abstracts, we were able to end up writing a few different papers, some of them being case reports, others being full research articles, and I think that is very helpful, not only in that you have scholarly activities to show, but also the relationships that you form with those mentors, and the advice that they're able to give, and point you in the right direction, and also act as strong letter writers that have not only seen you on maybe an inpatient service, but worked with you in clinic, and then seeing what you can do on the research side of things. I also think it's really important to show how well you work on a medicine team. A lot of cardiology is working with a multidisciplinary team. So how you work with the nursing staff and your interns and APPs and nurse practitioners all really matters. And I think the more that you can show you're an effective communicator, and you're able to coordinate complex care, goes a long way.
Awesome. Yeah, no, that sounds it sounds like that, mentorship's been like a key role, key part of your path for sure. And that makes sense. Like, I mean, I can say I've gotten to where I am as well, thanks to good mentorship as well. I think that a good mentor is priceless. It's definitely both as like a guide, but then also, as you said, like someone who can vouch for you when you go to apply for wherever you're trying to go. I guess kind of closing things out a little bit, we were talking about this. We both have this interest in medical innovation. Maybe tell us a little bit about like your interest in medical innovation, and where like kind of how you hope to integrate that into your career as a cardiologist.
Yeah, this is something that really excites me. Again, starting in medical school, I worked with a cardiologist that was developing a new assay. So I got to see kind of his decision-making process and how he would go through the steps of, testing, and then putting it out there, and then talking with industry partners about next steps. And, I found out about Emory's distinction in medical innovation. And that was something that was really appealing to me. And there's actually two tracks, one through the internal medicine residency, and the other kind of a graduate medical education GME-wide distinction track. So I was able to learn a lot about the innovation process from each of these tracks, and found out about all the different resources in the Atlanta area. One of them being our partnership with Georgia Tech, some of the smartest engineers right across town from us. And I most recently got involved in one of the biomedical engineering capstone projects biomedical engineering was my undergraduate degree, and I remember doing an undergrad capstone project. So this time I kind of flipped the script, and I was able to act as kind of the problem proposer and then the clinical mentor along the way. And the problem kind of came out of starting to do telemedicine visits at the onset of COVID, not being able to really conduct the physical exam, being pretty limited. In my interest in cardiology, I was interested to see if we could come up with a low-cost telemedicine stethoscope. And I was just astounded with what the team of engineers that picked my idea were able to come up with. Through the innovation distinction program, I learned about other resources in the area. We were exposed to working with the Office of Tech Transfer here at Emory, and I've seen how it works at Georgia Tech too. So we were able to pitch our idea and get a provisional patent. And I'm very happy to say, and very excited to say, the team, after they've graduated, has continued to run with the idea, and they're working on a second prototype to incorporate an electrocardiogram along with the telemedicine kind of auscultation capabilities. And we recently were awarded a venture prize to kind of fund our continued work. So I'm very excited to see where it goes.
Awesome. Congrats on that, man. That's really cool. And then to really see like an idea kind of come to full fruition like that. It's obviously, there's a lot of ideas out there, but actually like bring it to kind of a stage where you're, really making good headway on it. That's awesome. Congrats on that, and more success ahead, I hope.
Thank you. Thanks. We hope so too. We'll see. And this is an avenue that I think it just works very well with cardiology, as there's constant innovation in the field. And I do really enjoy telemedicine, and I know that there's actually a big place for it within the world of heart failure management. So I would love to be able to incorporate this later on in my career too.
That's great. And I think cardiology, like you said, it seems like there's always something new coming out in that field. So it's a very exciting field, and obviously heart disease continues to be a major health issue in the US and the world at large. So I'm sure it's a field that's, seen a lot of innovation, still ripe for even more innovation in the years to come. Well, Matt, to kind of finish this off here, I ask every guest this, in this age of trying to keep our lives balanced, what do you do with your free time outside the hospital when you're not developing telemedicine devices or working as a cardiology fellow?
Love spending time with my wife and my yellow lab puppy. We have been on plenty of adventures. We love going for big walks around the Atlanta area, stopping off at our local favorite place, the Family Dog, down in the Highlands, and also getting gelato at Paolo's Gelato Place. We also are lucky to have a relative out at Lake Oconee. So I have taken up the wakeboarding and been trying to stay on my feet on the board out there. I'm very lucky to be close to where I grew up. So my parents are around, and my little brother too. So it's always great to be able to spend time with friends and family. And I'm very excited to see more concerts become available. I've got a good group of friends that are really into music festivals, and we love to see live music come back into the field.
Yeah, definitely. That's awesome. Well, Matt, it's been a pleasure talking with you, and I've certainly learned more about the field of cardiology, and I'm sure the listeners have as well. So thanks for taking time on your busy schedule to join us, and really appreciate it.
Thanks so much for having me, Maxwell. This is great, and I hope this was helpful as medical students and residents go through internal medicine and think about cardiology.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as eBooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.